Thank you both for those great presentations. So I'm going to ask two questions and then open it up for questions from the audience. And I think you both touched on this. This is kind of a chicken and the egg question. So which comes first, the culture or the infrastructure? Right? So it seems like Trinity might be an example of the mission kind of driving the structure, the strategy, the planning, whereas perhaps Vanderbilt's new structure could actually create kind of a cohesive culture of health equity across the institution. So do you have thoughts about lessons learned, or kind of what's your perspective on that chicken and the egg?
Sure. Okay, if I go first? Oh, great. That way you can collect your thoughts since you just did such a beautiful presentation. Yeah, you know, it's been interesting because it is a chicken and the egg type of question. I would say that you know, as a faith-based organization and as a provider organization, we've always had kind of community health and health equity as part of our mission. But you know, quite honestly, we measured our impact. You know, if you look at and I'm a CFO, so you know, so there, a lot of this kind of comes back to the finance, and I always have to, you know, manage the tension that exists. But if you look at our audited financial statements, we have a footnote on our community benefit ministry, we call that. And we categorize, you know, our resources allocated to community benefit ministry. And, you know, the interesting part is that a large part of it is the unfunded cost of Medicaid. Mm-hmm. That's the formula. So, you know, what would drive kind of our investment in the community was the unfunded part, you know, the unfunded cost of Medicaid, and that's not really community health, mm-hmm. right? That's not community benefit. That's not really impacting the community. And for the most part, our leaders, the last 5% of what they did every day on the corner of their desk was the community health piece. So it just really wasn't getting what I would call is the drive, the attention, and the focus to really move the needle forward to make an impact on all the communities that we serve. So when we came together as CHE Trinity in 2013, and the clear mission was to be transformative, that really was a game changer for us, quite honestly. That being transformative was, you know, what really started to drive us to approach community health and well-being and health equity in a different way. And when you're a provider organization and you've been living, and your success for 100 years has been fee-for-service, it is really, really, really hard to to pull yourself away from that center of gravity. It's a strong gravitational pull. And so to stake out resources and stake out, you know, firm commitments to put individuals that are accountable, wake up every morning thinking about it, go to bed every night thinking about it, how are we impacting the community? For us, that was really the key. So the driver for us was really having it as part of our mission, having it as a priority from the board of directors, and then all the way down through all of our incentive systems. That's when we really started to move the needle in terms of community health and the investment in it, and beginning to make a difference, just beginning to make a difference in the communities we serve. Long-winded answer, but I wanted to kind of create that context.
I would say that the structure is the vehicle for us to actually change the culture. I think in an institution that is, you know, relatively large, has long-standing approaches and strategies, but also is incentivized to have these silos. It's very challenging to influence the culture without having the backing of the leadership, but also having sort of the structure to sort of drive people to. I think Eliza and I talk about this quite a bit because we've spent so much time over the last, you know, decade in the community that, you know, bridging with the community for us is going to be the easy part. Changing the structure internally is the more challenging piece. So, you know, how do we make sure that we're embedded in the curriculum when everybody thinks the curriculum is perfect? It just got redesigned, and all these other things. And so, but we have the students who are yearning for this, and already in our new health equity certificate program, we have students knocking on the door saying, when can I come in? When is the first class starting? We can get community members onto our grants and get them funded, but then finance wants to send them a vendor form that's 20 pages long, and they want they expect them to sort of pay out of pocket for 90 days before so all of those things is like, no, we can't do it like that. So, when I say I need my community partner to go with me to this meeting and I need to pay for their travel in advance and give them per diem, they're like, well, we don't do it that way. Okay, so we have to change those things. And so I think that's, a bigger part of changing the culture and getting people to really realize, why this is needed, how it's different, and if we design the wellness program for everybody who can afford childcare or doesn't have to worry about where they're going to get their groceries, then what about the people who can't even get off work to take their kids to their doctor's appointments? So I think that's part of what's really important with this process is the structure gets us in the door to change the culture, and then we get to point to the the C-suite to say they said we could do this, or they're behind this, and they're now incentivized in some way. So it's really hard, I think, to disentangle them.
Thank you. So my second question, and you both mentioned incentives, whether it's value-based purchasing incentives or metrics for the C-suite to kind of galvanize the work. And that leads me to a question of accountability. Right? So who at your organizations is truly accountable for the outcomes, the outputs, the products of this work? And sub-question, how do you ensure that all stakeholders, so the C-suite, patients, families, faculty, are actually engaged in the development of those incentives and metrics, so that they're meaningful to everyone involved?
So I'll start with this one and say, apparently I'm partially accountable with my new title, but fortunately, that with the incentives in place at the executive level and performance goals that we'll have that we're expected to report on, I think that holds the executive level to more accountability. But the fact that we're a nonprofit medical center means that we should be accountable anyway. So that should be, again, a part of how we see our mission and our responsibility is that we should be really advancing health equity in general. So I think that and I don't like to use the word empower because I don't think that we have the power to give to the community, but I think that it would be great for them to exercise that power and hold us accountable and call us out and ask why are you building this new facility without considering what our needs are, or bringing us to the table to see how we can be a part of it, how you can hire from the community, how you can use our resources, and I'm hoping that through opening these doors and making sure that they know we should be accountable, that they'll push us a little bit farther.
So, what we've done is we're all accountable in the organization. And the board holds us accountable for a number of goals in our annual plan and our strategic plan. 25% of those are related to community health and well-being. So it has equal weighting to finance, as an example. And it's from the top of the organization all the way down. We're distributed, as I mentioned, across 19 regions. So, alignment is really, really critical. And so the way that we do that is all of our executives, again, they have the goals related to community health and well-being, same goals that I have, same goals that our CEO has, and so forth. But in order to get extra focus and emphasis on it, we have a senior vice president for community health and well-being at the system office level. He sits in our executive leadership team. He's a member of the executive leadership team, so it's part of our leadership at the system level. And then again, at each of our regions, we have vice presidents that are also responsible and accountable, working with their CEOs on achieving the objectives of community health and well-being as well. So we have alignment relative to the goals, and then we have individual accountability in terms of who, as I mentioned, get up and think about this every day, and work particularly on the not just what we are offering in terms of making an impact in the communities, but also the partnerships, because these are all done in partnership, quite honestly. We just can't do everything ourselves. The power of partnership, power of matching resources, and so forth. But that is how we have alignment and accountability. And again, when I hearken back 10 years ago, when we didn't have that, we really weren't making a difference in the communities that we serve. This has really changed our approach, and it's been effective.
So if anyone in the audience has questions, please make your way to the microphones. I will. Great. Yep. And please state your name and your affiliation, John.
Good morning. I'm John Auerbach from Trust for America's Health. And, first of all, your institutions just do great work, and thank you for sharing and inspiring us today. I wanted to ask a question about, in addition to the work that you've already described, if your institutions are also considering actively advocating, maybe even lobbying, for policy change at the state level or local level or federal level. My experience, I'm a former state health official, and what I could find in terms of our colleagues in the hospitals is that they had their own agenda at the State House. And so they'd be actively up there every day advocating for things, and they'd be very effective in terms of the relationships with elected officials, but they were reluctant to put on that short list of priorities policies that would have the effect of improving overall health within the state. And so, how has that been something that's been possible to consider, and what are your experience in terms of the barriers to having that done?
So I'll say at Vanderbilt, I definitely won't say lobbying, because I'm not sure that I know all of the things related to that. But as far as advocacy and the work that we do, so I'm relatively new in this role and still trying to understand how we push things forward as opposed to just react to policies that are being, or bills that are on the floor. I would say that in general there is a lot of interest in that, and really more trying to navigate the best approach to doing so is something that we're considering. So, for example, we have a tremendous Department of Health policy led by Melinda Bunton, and so a lot of work sometimes starts with we're comparing this and this, and let's see what that really means, and how about this as an alternative strategy. Our approaches that I know we're doing really actively, but we're also trying to model what we think policies should look like across the state and maybe across the country. So thinking little policy internally is, are we paying our employees a living wage? And if not, when are we going to get to that? And so we're working with all of the departments to do so. I think we run the risk of not being disingenuous if we're sort of advocating for things that we're not prepared to do ourselves. And so walking that line, I think, is important for us to do. But I would love for us to have a more active role in advocacy, because so much of what we're talking about with determinants, influencers, drivers of health are happening outside of the healthcare setting. So.
I would just add that at Trinity Health, we call it advocacy, we are very active with advocacy both at the national level as well as at the state level. So we're not shy about it at all. At the federal and state level, for instance, we've driven for legislation around tobacco, not selling tobacco under the age of 21, as an example, and we've been very successful with pushing those initiatives state by state. Opioids and how opioids are prescribed and used, we've been very active in that debate as well. Housing, access, gun violence, particularly today, really pushing on more and more restrictions around guns, access to guns, background checks, and so forth. And it's even inside the organization, it's a bit of a hot debate. I will say it's been very kind of interesting to watch that evolve. But we are very active advocates. I would also mention that our own internal portfolio is about $9 billion, and we are also very active in shareholder advocacy as well. Influencing, CVS and Walmart and other organizations in these areas as well that align with our priorities.
Thank you.
Hi, Sally Kraft from Dartmouth Hitchcock. Returning to the question of accountability, and thank you for sharing how really you have advanced practices at both of your institutions. I'm curious as to what types of measures you're using related to accountability. Are these population health management measures within your health systems, or are they really community health metrics? And if they are community health metrics, Consuela, how do you deal with that fact that there are so many influences, not just the health system, on what health is?
So we are first trying to make sure that we understand what measures are being collected now, but also what we can reliably collect. So I think from the standpoint of community health outcomes, that's one of the reasons we are looking at internally at our employees as our first community, because there's some things that we'll be able to assess more easily among them and how we influence their health. We're developing metrics in all of the mission areas. So as far as the students, their competencies, their knowledge, their willingness to work in communities that in some research-intensive academic medical centers they've shied away from in the past. But we're still trying to determine the best way to assess this culture change that is really incredibly important. And if you have these measures out there, I need them. But how will we really assess the change in culture, which I think is going to sort of leapfrog us into being able to change outcomes more broadly. I think we probably have the best measures, although still not great, not exceptional as it relates to research, and mostly because those projects tend to be more finite. But we are looking at new ways of assessing how we integrate the voices of communities into our work. And I think a key piece there is, what did we change because of the input that we got? And not just we had an advisory board, or we had people at the table, we had listening sessions, but what do we actually do with that input, and how did it change the work, the process, how we consider priorities?
I would just add that we do have objective, measurable outcomes that we use. They are more, I would say, refined relative to the tobacco use and reducing tobacco use and obesity and childhood obesity. and really looking at the impact, through using our electronic medical records as evidence that we're making differences in those two arenas. Related to social influencers or health, which is a new one that we've introduced this year, which is community by community. Not as refined there yet. So when we're trying to impact, like in Hartford, Connecticut, the North Hartford community, which is a food desert, our ability, so we're taking that on with several community partners, but our ability to impact that, probably more of a process-based measure initially until we get to the outcome of we have established a sustainable place for the community to go get fresh groceries and so forth. So those are a little bit kind of longer timeline and not quite as objectively measurable as tobacco and childhood obesity.
If I could just quickly, though, say that Philip, as far as metrics are concerned, he has certainly nudged, I won't say shoved, but nudged us as we're thinking about metrics. Is that a health care equity measure or metric, or is it a health equity metric? So not just comparing people within the healthcare system or the clinical system of differences across outcomes, but if we're talking about health equity, is it a metric of actually food security, or are we just talking about differences in diabetes outcomes across people? So I think that's an important distinction as well.
So, Mr. Carter, first, a number of us in the roundtable are familiar with Kevin Barnett, your board member, who I know has been appreciative of the movement of senior leadership at Trinity in the directions that you've presented very well today. My question is about the $9 billion. And is there anything that you as a CFO could tell us in terms of federal or state policies that would give you as a mission-driven, value-driven CFO more freedom to align those investments with the community goals we're talking about? So much of what we're looking at is sort of percentages of margins of mainly that come off clinical operations. I'm curious, as a CFO, could you give us any guidance as to policies that would give you more freedom to use that corpus in more creative, community-friendly ways?
I've never been asked that question before. Policies at the state and federal level, for instance, are you thinking of?
Yeah, the roundtable has a megaphone that we can't lobby either, but we can bring to view policies of government that could help healthcare do more of what, in your case, I know Trinity really wants to do. And I'm sure as a CFO, you're constrained in many ways you can't just take that $9 million and do whatever you want with it. I'm just curious, are there any policies that might protect you and give you more freedom?
I think that nothing like immediately jumps to mind, I would say. Kevin has obviously been very influential on our board and helping to guide us as well. And for instance, we've taken $75 million of our portfolio and have dedicated it to social responsibly investing, as an example. So part of as I mentioned, $40 million going towards low interest loans for for housing development, for education, and items like that will influence I would say that to the degree that if you're thinking of so when our investment subcommittee and the stewardship committee looks at the return on investments, when you allocate part of your portfolio, or you eliminate as part of your investment in your portfolio certain things that might otherwise move a stock index up, and you're going to lag it as a result of not having to be, not allocating towards it. I think to the degree that we have more allowance or freedom, around being able to make decisions about socially responsible investing and not get otherwise, affected by in terms of, well, what's your performance on these is always a very helpful support that we need.
Thank you.
So being mindful of the time, I think we have one more quick question, if you can. Thank you.
Hi, Mylyn Tufte with the North Dakota Department of Health and part of the roundtable. Thank you for your discussion today. My question has to do with the language that we're using and maybe the tension that comes with people that aren't as in the trenches around health equity and how you use that to help inform the mission and the vision that you're doing within your organizations. For us in North Dakota, we heard some discussion about urban versus rural, and there are disparities related to equity around that. So a lot of people, when they hear health equity, sometimes in their mind, it comes straight to race. But there are other disparities that we face within our state. And you are addressing those within your organizations as well. So maybe you could talk a little bit about disparities that aren't just specifically race-based or place-based. Maybe you can address that in your discussion. Thank you so much.
I couldn't agree more about the importance of language in so many ways. To communicate with the different levers within the medical center requires some code shifting at times and how we actually explain things and make sure that people are aware of those of the importance of this work. I do think that often when we say the community, people think there's just one community and they have their idea of where that community is and who's in it. And so we do try and spend some time really sharing what we mean by communities and how different communities are, and particularly thinking about, as Sally and I were talking briefly earlier about in rural communities, there is no YMCA or community health center. So where do you go and what does that look like? So maybe that's where the volunteer fire department is sort of a nidus or central place in some communities, and making sure that we're using language that helps people identify what that looks like in their own communities is pretty important. So.
Well, thank you, Consuelo. Thank you, Ben. Please join me in thanking them.